Okay, so we're going to do some training with the goals of making sure that we have an accurate and reproducible way to evaluate the patients that we want to include in the clinical trial. So the EULAR Sjogren's Syndrome Disease Activity Index is a mechanism by which we can evaluate systemic activity, and it's designed to measure disease activity in patients with primary Sjogren's, but it's growing and it's becoming a gold standard in the evaluation. And with increasing use and its dependency to be used as a good outcomes measure, it becomes challenging in rating these domains. So our goals today are to go through each of the domains individually. So we'll talk about the development of the ESSDAI, the domains. We'll talk about the protocol somewhat, go through some case scenarios if time permits, and address questions. So each domain, and again, these domains were established by our European colleagues, bringing many of them together, going through their individual patients and selecting particular parameters for each of these patients in which we see the disease characteristics and putting them in an integrated platform for which we can evaluate each system according to the domain. The ESSDAI is a systemic disease activity index, so we're trying to see the activity of disease involvement in the patients we're evaluating. It includes 12 domains, each with 3 to 4 activity levels. And as I said, it's growing use, has its inclusion in most clinical trials of Sjogren's disease. Now, my plan was to be somewhat repetitive, and so you're going to see it once, you're going to see it twice, you're going to see it another time, and so we're going to try to really imprint and impress. So when we look at each of the domains, and they're listed here: constitutional, lymphadenopathy, glandular, articular, cutaneous, pulmonary, renal, muscular, PNS, peripheral nervous system, CNS, central, hematologic, and biologic. The activity levels, the numbers of activities that we'll be evaluating, and then the total maximum score. If there's no disease activity, it'll be 0, and then it'll be given a particular numeric value for the presence of either low, moderate, or high disease activity. And the CNS is unique in that there is no 0. You either have it or you don't. And so we'll go through initially general instructions. We'll go through exactly what Professor Sarar had in her paper in describing the ESSDAI. And we'll be using the one with the most current revisions because the pathogenesis is changing and there have to be adaptations to that. So again, patients with primary Sjogren's and only signs and symptoms associated with Sjogren's syndrome should be scored. We have to exclude damage that are irreversible because we can't treat them and change them. A score of 0 is given if the abnormality is long-lasting and the features are fixed and it's been stable for a period of at least 12 months. So we'll start with the constitutional domain. We exclude here fever of infectious origin and any voluntary weight loss. The activity levels are 3, no activity, low activity, a 3, and a moderate is a 6. No activity is the absence of any of the symptoms that I'll be describing. A low is mild or intermittent fever, and that would be 37.5 to 38.5 degrees centigrade, and I think we figured that out, 99.4. We'll have it in another slide for the low number. And night sweats, which can be present with addition or without the addition of involuntary weight loss of 5 to 10% of body weight. A moderate would get a activity level of 6, and that would be a step higher. Severe fever greater than 38.5, with night sweats and or involuntary weight loss greater than 10% of the body weight. And as I go through this, you'll see what we'll do in each of these domains. So 0 would be no disease activity, no constitutional symptoms at all, and symptoms that are due to other causes, menopause, infection, weight loss. Whereas a low disease activity level, and there we have our Fahrenheit and centigrade measurements, that's mild intermittent fever, night sweats that do not wet the clothes, and involuntary weight loss, 5 to 10% of the body weight, and then the moderate would increase to greater than 38.5 or 101.3, at least twice a week, night sweats that do wet the clothes, and involuntary weight loss of greater than 10% of the body weight. So for all activity levels, we have to engage the patient. We have to talk to them. We have to ask them, have you had fevers or night sweats in the past 4 weeks? So we're looking at a period of over 4 weeks. And fever has to be confirmed by the patient or physician with a thermometer reading. And weight loss has to take into account the previous 3 months. Constitutional symptoms can possibly be related to lymphoma. And if so, they should be scored both in the constitutional and the lymphoma domains. So this is our summary. We have the disease activity. If not, everything is absent, or weight loss less than 5% of the total body, because you have to have greater than 5. And if you look at each of the lines going out from the activity level, it's going to be an or. So a low disease activity can have fever, or have the night sweats present, or have the weight loss 5 to 10%. Moderate would be fever, greater than 38.5, patients with wet clothes, you've asked them, yes, they do, or weight loss greater than 10%. Is that pretty clear? Okay. Go ahead, yes.
So the first slide talked about these criteria being developed for primary Sjogren's syndrome, but you're talking about applying these to all the patients in this study, right?
That's correct, yes. And that was Dr. Soror's purpose in making these, specifically with her abstract. Those are the patients that she described. But these are to all of our patients, so they're going to be universal.
Is it fever or weight loss?
Fever or weight loss. All right, so if you go down just like in a diagonal there, and I don't have a pointer, but the lighter line, the darker line, the lighter line, or. That kind of makes it easy. And you'll have your cheat sheet. So this, our test that we'll do afterwards, and if you don't get a 99.9% with memory, we'll just have you sit here and go through it again. So the next is going to be our lymphadenopathy and lymphoma. And she actually went back and added the lymphoma to this lymphadenopathy domain. And so here is an exclusion of infection. We have 4 activity levels, 0, 4, 8, and 12, depicting no activity, low activity, moderate, and high. The description of no is absence of all the oncoming features. A low 4 activity level would be adenopathy. I kind of remember this as being 1 and 2, then we go 2 and 3, down for the moderate. But lymphadenopathy, 1 or more centimeters in any nodal region, or 2 or more in the inguinal region, 2 or more centimeters in the inguinal region. That gets you a 4. A moderate would be lymphadenopathy, we're moving up a centimeter, 2 or more centimeters in any nodal area, or 3 or more centimeters in the inguinal region and or splenomegaly. A 12 then would be current malignant B-cell proliferative disorder, and obviously that patient would be excluded from our trial. Okay, and here's our repetition here. So no disease activity. If no significant adenopathy or splenomegaly, a physical examination, and lymphadenopathy is due to any cause other than Sjogren's syndrome. Low lymphadenopathy, and then we have our greater than 1 centimeter in a nodal, or 2 or greater centimeters in an inguinal. Then escalating up to moderate disease activity, lymphadenopathy describing 2 or greater centimeters in a nodal, and 3 or greater centimeters in an inguinal region. And then splenomegaly, that can be clinically palpable or enlarged by imaging. You may not have imaging, but if you do, you'll use that. Okay, high disease activity, any B-cell malignant disorder should be taken into account unless it is in complete remission for more than 6 months after the end of treatment. So 6 months out in remission, it's going to be not taken into account. Diagnosis based on the WHO classification criteria in 2011. Conditions that should not be scored include monoclonal gammopathy of uncertain significance, multiple myeloma, and that lymphoma that would be considered in remission, complete remission for more than 6 months after the end of treatment. Yes? That's correct. That's correct. But it's included, and she wanted to put that there, and we're following her guidelines. Dr.
This is a general SI training that we're giving, and I will talk a little bit later about the specific protocol consideration. As with any clinical trials, this is a proof of concept study. We do have exclusion criteria, and some of them, like if you have a high disease activity, in some of the SDAI scores, that would also exclude you. And again, we're seeing this as a general SDAI training today, and I will talk about the protocol consideration following Dr. Ford's talk. Thank you.
All righty. And as a summary, general instructions, imaging is not required, as I mentioned, but if we have it, ultrasound or CT scan, it should be used for scoring. And if no imaging was performed, your physical examination findings should be used. And again, the summary slide, lymphadenopathy is going to be either any region, any nodal region or inguinal region. No or 0, everything is absent. Low, greater than 1 or more centimeters in any region, 2 or more in the inguinal, without splenomegaly, without concurrent B-cell malignant disorder. Moderate, greater than or equal to 2 centimeters, any region greater than or equal to 3 in the inguinal, so the inguinal requires a larger node. So it can have either or, greater than 2 in any region, or greater than 3 or equal to in the inguinal region, or splenomegaly, or splenomegaly. And high would just be the B cell, which we'll address that later, okay? Now going to the glandular domain. Here we have exclusion of a stone or an infection, and we have 3 levels here, 3 activity levels, 0, 2, and low. 0 is the absence of glandular swelling, whereas 2 would be any small glandular swelling with parotid, and we're looking at the parotid, we're looking at the salivary glands, the parotid, the lacrimal, and the submandibular, or the parotid, the submandibular, and the lacrimal. And going in that order, the small glandular swelling, 3 or less centimeters in the parotid, 2 or less in the submandibular, and 1 or less in the lacrimal. So these are smaller areas as we are descending here, so that kind of makes sense. Moderate would give you an activity level of 4, and this would be, as opposed to small, major glandular swelling with enlarged parotid. Now we're saying 3 or greater, or important submandibular, 2 or more, or lacrimal, 1 or more centimeters of enlargement. So the glandular domain, no activity if there's no swelling, and if there's any swelling due to any alternative causes, such as stones, infections, lymphoma, cancer, and others, these are going to be excluded with the absence of glandular involvement. Low, again, remembering mild swelling in that category and more major swelling in the moderate category, starting with that 3, less than, 2, less than, 1 less than, parotid, submandibular, lacrimal, in that order, and I just kind of mentally draw a little line. And moderate being parotid greater than 3, submandibular greater than 2 centimeters, and lacrimal greater than 1. So general instructions, swelling of any of these glands should be assessed by clinical exam and not by ultrasound, so so it's going to be your examination. And if a particular gland, for example, the right parotid is enlarged due to lymphoma, and the swelling of the gland should not be then measured in the glandular domain. But if in addition, there's a gland like the contralateral, the left gland or other salivary gland is enlarged independent from lymphoma, then it should be scored under the glandular domain. Does that make sense? Okay, somewhat, huh? So we'll see it additional time.
You may not always know what's coming from lymphoma and what's coming from Sjogren's.
That's right. So if there is a glandular, I mean, we're talking about something that's, here the differential is whether that's going to be scored independently in the glandular or independently in the lymphoma, and we'll get to that. but the lymphoma, you can score both. So you can have lymphoma on one side and glandular involvement on the other side. And if the characteristics are met, you score both. And that's the point of this one. You might not always know, and that's the truth, but if you do know, you're going to be able to score it. Okay? So, yeah, so there's going to be the independent scoring and the possibility of scoring on both sides. So that was a little confusing to me when I first read that, but either or both, okay? And here's our graph, no activity level versus low and moderate, and we're going to be looking at 3, 2, and 1, the larger, the smaller, and the very small, parotid, submandibular, lacrimal, 3 or less, 2 or less, and that's or, okay? It can be in the parotid, or the submandibular, or the lacrimal, and the moderate, again, greater either in the parotid, submandibular, or the lacrimal, okay? So now we're going to the articular domain, and this is exclusion, if possible, of any other type of arthritis, specifically osteoarthritis, and we know the joints of involvement should be more perhaps distal interphalangeal involvement. 4 levels here, 0 to 0, low, moderate, and high, with activity levels in the low of 2, moderate of 4, and high of 6. So in the 0, no currently active articular involvement. 2 is arthralgias, hands, wrists, ankles, and feet. And this has to be accompanied by morning stiffness of greater than 30 minutes. So not just the arthralgias, but morning stiffness is important as that activity level determination. Moderate, and we're going to separate here with 5 or less, or at least 1 to 5, or 6 or more. And it has to be a total joint count with synovitis, and that means swelling and evidence of active inflammation. No activity. Low, arthralgias with the morning stiffness. Moderate would be joint swelling of 1 to 5 of the 28 joints, and high disease activity, joint swelling of 6 or more with synovitis. Yes?
In the mild activity arthralgias, you list 4 different sets of joints. You mean all of them together?
Let me see if I understand what you're saying.
Somebody says my hands and feet hurt, but my ankles don't.
If you're counting that 1 to 5, it's going to be in the, so.
No, I'm talking about mild disease activity, just arthralgias, no synovitis.
Right.
Okay,
So
and
if
somebody
there's
complains, I have morning stiffness and hand pain, but doesn't complain of pain in other joints. Does that count?
So if it's not swelling,
Right.
and it's not, and so that does not, I'm not saying does it not count.
No, I'm just
for-
asking, you list 4 sets of joints, hands, wrists, ankles, and feet.
Right.
for
but hands
arthralgias.
have 10 fingers.
No. That's not what I'm saying. Can you go
Okay,
back to
sorry.
the slide?
Is it an and or an or?
It's a low activity level. Arthralgias, do you mean in hands or wrists or ankles or feet? Or do you
Yes.
mean in all joints
No.
together?
Or.
Okay.
Or. I understand, I'm sorry. Okay. So again, based on your question, and this is where you would ask the questions, have you had pain in your hands, wrist, ankles, and or feet in the past 4 weeks? And do you have morning stiffness for more than 30 minutes? So you're asking and you're delineating. Presence of synovitis is based on your clinical examination or by the medical professional. Arthralgias and synovitis, due to other reasons such as OA or RA, should not be scored. And obviously, this is your evaluation, and we're not always 100% on point, so we're going to do it the best of our ability, okay? And I think the key take-home here is that we're talking about arthralgias, which is tenderness, and then synovitis, which is going to be swelling, okay? And the articular domain then, low, as I said, arthralgia, moderately the synovitis with the 1 to 5, and the high greater than 6, out of a total of 28 joints, 10 hands, each wrist, 2 more, and we have our ankles and our feet, okay? So the cutaneous domain, it will rate as no if there's stable, long-lasting clinical features related to damage, and these are 4 levels, low, moderate, and high. and 0 would be absence of currently active skin involvement whatsoever. A low will be erythema multiforme. Moderate would be a limited cutaneous vasculitis, including urticarial or purpura that is just present on the feet or ankle, or any subacute cutaneous lupus. And a high would be a diffuse vasculitis, including urticarial or diffuse purpura or ulcers related to the vasculitis. So no disease activity would be no skin involvement that's attributable to the Sjogren's. Stable, long-lasting lesions related to disease damage, and a cutaneous rash unrelated to Sjogren's due to any other etiology, infection, drugs, or lupus. The low disease activity is multiforme. Moderate would be SCLE, purpura limited to the feet and ankles, and the limited cutaneous vasculitis, including urticarial, that involves less than 18% of the body surface area. And everybody knows how to measure the body surface area. Patient's palm, and I'll show you another graph to be able to determine that, okay? Cartoon to show you that. Diffuse cutaneous, including urticarial, would be greater than 18% of the body surface area. So here's our homunculus, and 9% body, front 18%, back 18%, upper extremities 9%, and the legs 18% each. The graph shows that. And you know, this is our model, but using the hands to determine the body surface area. The palm is another easy way to do that. So, cutaneous vasculitic lesions other than purpura should be confirmed by either histology or the presence of cryoglobulins at least once in the patient's history. And if a skin biopsy has been done, then we use it for scoring. If no biopsy results are available, scoring is based on your clinical examination. And here are the nice pictures. In the upper left is our classical erythema multiforme, the heaped up edges, somewhat central clearing with erythematous ring. The SCLE, which would be in that moderate. And then we have the purpura and limited vasculitis on the foot on the left lower panel, and then more extensive with perhaps an ulceration in the medial aspect that maybe we can't see. So that just gives you a visual there. So looking at our graph, no disease activity, none of those. Low would be the presence of E. multiforme. That's the only one in that area. Moderate would be SCLC or purpura limited to the feet and ankle, and or limited to less than 18% of body surface area with a cutaneous vasculitic rash. High would be either diffuse purpura or greater than 18% of body surface area with the presence or the presence of ulcers. So we're going on the pulmonary domain, which is a little bit more wordy, and I'll go through this. We rate as no activity if it's stable, long-lasting features related to damage or respiratory involvement not related to the disease, such as tobacco use or some other toxin. No would be the absence of any currently active pulmonary involvement. A low, which would be a 5, would be a persistent cough due to bronchitis and bronchial involvement with no radiographic abnormalities on plain X-rays or radiological or high-resolution CT evidence of interstitial lung disease, with no symptoms of shortness of breath and having a normal lung function test. Moderate would be a 10 if there is moderately active pulmonary involvement, such as interstitial lung changes on HRCT, some symptomatic shortness of breath on exercise by NHYA2, or abnormal lung function test related to the diffusion capacity with the LCO greater than 70%, greater than 40%, from 70% to 40%, or 80% of functional vital capacity being greater than 60, between 80 and 60. High activity level would be a highly active pulmonary involvement, such as interstitial lung disease, evident on HRCT, with symptoms of shortness of breath at rest, so the New York classification 3 to 4, with abnormal lung function tests. So there, the diffusion capacity would be less than 40 or FVC less than 60. And let's see. So no disease activity, no symptoms, cough just due to some bronchial dryness, irritation, stable, long-lasting over a year, features such as cough, shortness of breath, or ILD related to damage. Becomes low if there is bronchial involvement that's ascertained by radiographic evaluation, HRCT, with bronchial thickening or dilation, or PFTs, which would indicate an obstructive syndrome, with X-ray evidence of ILD without clinical correlation, so the patient without shortness of breath and normal PFTs. Moderate would be the ILD with a clinical correlate of either the New York classification or PFTs with 70 or greater diffusion, or between 70 and 40, making that clear, or between 80 and 60% with the forced vital capacity. High disease activity then would be ILD with a clinical correlate, patient symptomatic, with abnormal PFTs, with diffusion capacity less than 40%, or forced vital capacity of less than 60%. Shortness of breath due to non-Sjogren's causes, such as COPD with tobacco-related bronchitis, cardiac insufficiency, pulmonary embolism or infection should not be scored. Imaging confirmation of suspected interstitial lung disease is required at least once somewhere in that patient's history. And for follow-up scoring, it should be based on either their PFTs and or clinical symptoms, and this is our graph. No disease activity would be cough due to dryness with normal PFTs and imaging, or with stability over a year can be abnormal, but it has to be stable over a year. And again, that's the PFTs, the imaging, abnormal but stable over that period of time. Low disease activity would be cough due to bronchial involvement, obstructive changes on PFTs and evidence of bronchial thickening on radiographs, or no clinical symptoms, normal PFTs, but evidence of ILD on imaging. And mild symptoms, mild shortness of breath, slight limitation with function, and that parameter with DCLO greater than 40 and at least 70, and the FVC 80 to 60 with imaging of ILD. High would get that patient with moderate to severe limitation of activity, even with less than ordinary activity, even walking short distances. And we'll talk later, and Dr. Metzges will talk about those patients that we'll obviously be excluding, but again, for purposes of going through Professor Sarar's activity indices, we're including this. And this would be the diffusion capacity of less than 40 and a forced vital capacity, or forced vital capacity less than 60 with ILD. So the renal domain, again, and if you remember the very first slide, these get a little bit heavier weighted rating. And the renal rating, if no activity, would be stable, long-lasting features related to renal damage, and not related to any disease, not related to the Sjogren's disease. And if a biopsy has been performed, we have to rate activity based on the histological features first. So we look at that. If a biopsy is available, that kind of trumps everything we're looking at initially. So if a patient has no currently active renal involvement and they have less than 0.5 grams per day of protein, no hematuria, no leukocyturia, no acidosis, or any long-lasting stable long-lasting stable proteinuria due to damage, they can be a 0. So less than 0.5 without hematuria, leukocyturia, acidosis, or stable proteinuria due to damage. Low would be evidence of mild active renal involvement, limited to tubular acidosis without renal failure, or glomerular involvement with proteinuria. That would be between 0.5 and 1 gram a day without hematuria or renal failure. And then a moderate, and then the GFR should be greater than 60, estimated GFR, greater than 60 cc's per minute, Moderate would receive a 10, and that would be moderately active renal involvement, such as tubular acidosis with renal failure, GFR less than 60, or glomerular involvement with proteinuria between 1 and 1.5 grams per day, with no hematuria or renal failure with a GFR of greater than 6 cc's per minute, or that histological evidence of extramembranous GN or important interstitial lymphoid infiltrate, and a high would be highly active renal involvement, such as glomerular with proteinuria more than 1.5 grams a day, or red cells in the urine, or renal failure less than 60, or histological features of proliferative GN, or cryoglobulinemia related renal involvement. And obviously this will be one that you'll want to look at your notes and compare. So no disease activity, and I won't go through that again, but if you have other causes other than the Sjogren's related, like angiosclerosis, diabetes, associated with some endocrine disease, drugs, viruses, hematologic disease, or other systemic diseases, not Sjogren's related. If it's been greater than 12 months, non-evolving renal involvement due to damage, and so you could have a GFR as less than 60, but if it's been stable, okay, over a period of greater than 12 months, then there's no activity because it's stable, or the absence of currently active renal disease. Then we step up to low disease activity if there is tubular acidosis without renal failure, so the GFR estimated to be greater than 60, glomerular infiltrate with proteinuria 0.6 to 1 without hematuria, without renal failure. Moderate steps up to tubular acidosis with renal failure, and here our GFR decreases beneath 60 cc's, and the glomerular involvement increases 1 to 1.5 a day, no hematuria, no renal failure, with histologic evidence, and that's always a help. If you have a biopsy, it's going to help you immediately. So the histological evidence of extramembranous GN or important interstitial lymphoid infiltrate, and high disease activity goes to renal failure with the GFR less than 60, red cells, protein greater than 1.5, and our biopsy with histological evidence of proliferative GN or cryoglobulinemia-related renal involvement. So if a renal biopsy has been done, use it. If there's no biopsy, then you're going to look at the proteinuria, we're going to look at hematuria, the urinary pH, blood testing used for scoring. And renal tubular acidosis will be defined by the presence of hyperchloremia and low serum bicarb levels, both outside the normal lab standard values. Graph, helpful here again. I call this my cheat sheet. No activity if it's less than 0.5 grams per day of protein, no cells, no tubular acidosis, and a GFR that's greater than 60. More stable proteinuria, stable GFR. Then low would be 0.5 to 1 grams of protein with no hematuria, but the GFR would be normal. Or absent hematuria, present tubular acidosis with a normal GFR, or tubular acidosis with a low GFR, okay, without the proteinuria. Then it steps up to moderate with the increased protein, 1 to 1.5, GFR normal, or your biopsy evidence of membranous GN, or some interstitial changes. High would be greater than 1.5, or hematuria with GFR less than 60, or histological evidence by biopsy of proliferative GN or cryoglobulinemia-related renal dysfunction. That's a mouthful for both that pulmonary and renal, but you'll have your sheets to compare. So now we're moving on to muscles, and here we have an exclusion of weakness due to steroids. Activity levels 4, 0, low, moderate, high, rating 6, 12, and 18. Again, a heavily rated disease activity level. No being the absence of currently active muscular involvement. Once we have myositis, then we start scoring here. And the myositis should be determined on EMG, MRI, or biopsy, okay? But no weakness, and a CK that is going to be maybe a little bit upper limits of greater than normal, but less than twice normal values, less than equal to twice normal. A moderate moves up to moderately active myositis, again proved by EMG, MRI, or biopsy with weakness. And the maximal deficit shouldn't be any greater than 4/5, or elevated CK between twice normal and less than 4 times normal CK, and a high would be greater than 18 with highly active myositis, again proven, with weakness less than or equal to 3/5, or elevated CK greater than 4 times normal. So no activity due to other causes, fibromyalgia, corticosteroids, statins, or other classified autoimmune disorders with no evidence of activity. Thank you. Do I sound like I'm dry? You all should know how this sounds now. Okay, this is important. Important feature for pre-screening. So low disease activity level, proven myositis, and only muscular pain but no muscular weakness, and a normal CK. We're going to just ace my exam at the end of this. No weakness and CK elevation, upper limits of normal, less or equal to measured CK values, but less than 2 times upper limits of normal. Moderate then maximum deficit of 4/5 with weakness, and CKs between 2 times upper limit of normal, less than 4. High disease activity deficit 3/5 or less with CK elevations of greater than 4 times upper limits of normal. And so the diagnosis, again, of myositis should be made on clinical symptoms, muscular pain, weakness, and or CK elevation, and muscular involvement proven by one of the exams that are listed here: abnormal EMG, MRI, consistent with diffuse inflammatory changes, biopsy with active myositis. And if that's there, you only need to do that once. You don't need to repeat a biopsy. So muscular domains low, moderate, high, either muscle pain with normal CK or no weakness with elevated CK, as the parameters are shown here for low. Moderate would be between 2 and 4 times upper limits of normal, and the maximum muscle deficit 4/5. And high then goes up to either greater than 4 times upper limit of normal and muscle weakness with a deficit of 3/5 or less. Then this is proven myositis. So now we're going to PNS, another lengthy. We're over halfway there. We had 12, we're up to 9, only 3 more to go after this. So all of you that have stayed awake and are attentive, I appreciate it. So with PNS, we're going to rate as no activity if it's stable, long-lasting, and with features related to damage or PNS involvement that's not related to disease. And here we only have 3 levels: no, low. 3 levels. We have low, moderate, and high. With 0 being no evidence of active PNS involvement. Low, which would get an activity level of 5, and that's mild PNS involvement, such as a pure sensory axonal polyneuropathy. That's shown by nerve conduction studies or trigeminal neuralgia, and the proven small fiber neuropathy by skin biopsy was actually added because of the changing pathogenesis and the clinical studies that showed that that was significant. And they added that item it was not included in her initial version because the link wasn't established at that point. And not until recently was the cardiac inflammatory demyelinating polyneuropathy, nerve conduction velocity evidence was significant. So moderate would be 10, and then we're moving up to active PNS involvement. That's shown by nerve conduction with the axonal sensory motor deficit of 4/5, pure sensory neuropathy with the presence of cryoglobulonemic vasculitis, ganglionopathy with symptoms restricted to mild to moderate ataxia, inflammatory demyelinating polyneuropathy with mild functional impairment, and the maximal motor deficit of 4/5, or mild ataxia or cranial nerve involvement of peripheral origin except the trigeminal neuralgia. Then it becomes high, and these are the patients, obviously, they're going to probably need some more intensive therapy. Highly active PNS involvement shown by nerve conduction velocity, such as that axonal sensory motor neuropathy with a motor deficit of 3/5 or less. Peripheral nerve involvement due to vasculitis, so mononeuritis multiplex, severe ataxia due to a ganglionopathy, inflammatory demyelinating polyneuropathy with severe functional impairment with motor deficit of 3/5 or less, or severe ataxia. No disease if it's thought to be something else, diabetes, toxins, some other metabolic or inherited causes, greater than 12 months, non-evolving neurological involvement thought to do with damage, and no evidence of active PNS involvement. Low being the pure sensory axonal neuropathy, trigeminal neuralgia with a skin biopsy proven small fiber neuropathy. Escalates to maximum motor deficit of 4/5 with sensory motor, or pure sensory axonal neuropathy with cryoglobulonemic vasculitis. Ganglionopathy with mild to moderate ataxia, CIDP with mild ataxia or 4/5 motor deficit, or cranial nerve involvement of peripheral origin with the exception of trigeminal neuralgia. And it's high if the motor deficit is worsened, 3/5, if the nerve involvement, peripheral nerve involvement is due to vasculitis, if there's severe ataxia secondary to the ganglionopathy, or if the CIDP has severe ataxia or worse than 3/5 motor deficit, worse than or equal to. And so for all peripheral neuropathies except cranial nerve and small fiber, involvement should be confirmed at least once by a nerve conduction velocity, once in time. And the small fiber neuropathy should be confirmed at least once by either skin biopsy and or altered or absent laser evoked potentials and or an abnormal quantitative sensory testing to thermal stimuli and or sympathetic sensory testing. And basically pretty straightforward. These are a reminder of what it means to how we evaluate the grades of weakness. For 5/5 is complete range against gravity and resistance. 4/5 is a little less, as you can read here. Complete range of motion against gravity with a little bit of resistance, and 3/5 is complete range against gravity with no resistance, and then 2/5 would be complete range of motion with gravity elimination. They can't move at all. 1/5, a little bit of muscle contraction, no movement, and 0/5 is close to not being around. So our list here, this is the or. Low if it's a peripheral nerve, pure sensory axonal, or small fiber neuropathy, or trigeminal neuralgia. The moderate then is the motor sensory neuropathy, maximal deficit of 4/5, or sensory axonal neuropathy with cryoglobulonemic or CIDP with mild ataxia, 4/5 motor, or with involvement of the cranial nerve, any involvement with the exception of trigeminal neuralgia or ganglionopathy that's present with mild to moderate ataxia. High moves up to the maximal motor 3/5 or less, or involvement due to vasculitis, or CIDP with severe ataxia with the 3/5 or less deficit, or severe ataxia present with ganglionopathy. Now, CNS domain. Oops. So we rate as no activity if there have been long-lasting features related to damage or CNS involvement. Am I doing something here? Am I okay? That CNS involvement not related to the disease. 0, absence of currently active CNS involvement at all. And then we go up to a rating, an activity level of 10, which would be a moderate. And as we saw before, that it's either or, actually, with a moderate or high. Moderately active CNS features such as cranial nerve involvement of central origin, optic neuritis, or MS-like syndrome with symptoms restricted to pure sensory involvement or proven cognitive impairment, and this may be the patient that has white lesions on MRI relating to that MS-like syndrome. High of 15 would be highly active CNS features, such as cerebral vasculitis with cerebral vascular accident, stroke, or transient ischemic attacks, seizures, transverse myelitis, lymphocytic meningitis, multiple sclerosis-like syndrome with motor deficit. So no disease activity if something is long-standing, activity due to other autoimmune disorders such as MS, CVA or the white matter lesions likely due to atherosclerosis or embolic phenomena, infection, or autoimmune disease, lasting greater than 12 months, something that's not evolving, thought secondary to damage, or the absence of currently active CNS. Moderate moves up to cranial nerve involvement due to central origin, optic neuritis, or MS-like syndrome with a pure sensory impairment or cognitive impairment, and then high being the cerebral vasculitis with CVA or TIA, seizures, transverse myelitis, lymphocytic meningitis, or MS-like syndrome with motor deficit. So if there is expected CNS symptoms, except for lymphocytic meningitis, it should be supported by abnormalities on MRI. And optic neuritis should be confirmed by either visual evoked potentials or an MRI. Hematologic, only 2 more to go here. So we're going to look at hematologic, and this is really pretty much straightforward. For anemia, neutropenia, and thrombocytopenia, it should be an autoimmune-related cytopenia. So we're talking about antibodies here. So that should be considered with the exclusion of a vitamin deficiency or iron deficiency or drug-induced cytopenia or anemia of chronic disease. 0 would be absence of any autoimmune cytopenia. Here we have low, moderate, high. Low is 2, moderate is 4, high is 6. Low would be any cytopenia of autoimmune origin with neutropenia with neutrophils greater than 1,000 or less than 1,500, and or anemia with a hemoglobin of greater than 10, less than 12, and or thrombocytopenia, or platelets greater than 100,000, less than 150,000, or lymphopenia with greater than 500, so between 500 and 1,000 lymphocytes. Moderate would be cytopenia of autoimmune origin with neutrophils between greater than 500 but less than 1,000, and or anemia, and the parameters there for the hemoglobins would be hemoglobin B greater than 8 but less than 10, and or thrombocytopenia greater than 50,000 but less than 100,000, or lymphopenia greater than or equal to 500. And it becomes high if there's a cytopenia present of autoimmune origin, again with neutropenia, with the neutrophils that are 500 less, and or anemia less than 8, and or thrombocytopenia less than 50,000 millimeters squared. So low would be neutrophils between 1,001 and 1,500, lymphocytes 501 to 1,000, hemoglobin between 10 and 12, and platelets between 100 and 150. Moderate would be between 500 to 1,000 white cells, lymphocytes less 500 or more, hemoglobin between 8 and 10, then the platelets going down between 50 to 100,000, and a high would be less than 500 on the neutrophils, less than 8 on the hemoglobin, and platelets less than 50,000. And finally, home stretch here, biologic domains. I hope everybody's remembered every single thing. But did I say 99.2 is the passing score for the test I'm going to give? So biologic domain, 0, 1, and 2. So the absence of any biologic features is a 0. A low would be any clonal component and or low complement, C4, C3, or CH50, and or hypergammaglobulinemia or high IgG levels between 16 and 20 grams per liter. And then a moderate would be presence of cryoglobulinemia and or hypergammaglobulinemia or high levels of IgG greater than 20, and or recent onset of hypogammaglobulinemia or recent decrease in IgG levels less than 5 grams per liter. So biologic presence of cryoglobulinemia should be taken into account, even in the case if there's low cryocrit levels less than 1. Clinical signs of cryoglobulinemia should be additionally scored in each domain. Clonal component can be detected by serum electrophoresis, serum or urine immunofixation, or by an abnormal ratio of free light chains in the serum. And those are labs that you can obtain. So looking at our graph, low activity level, total IgG 16 to 20, any decrease in complement below the lower limit of normal in either C3, C4, or CH50, a clonal component being present. Moderate would be cryoglobulins, or total IgG greater than 20 or less than 5 with a recent decrease. And there you have it. Okay, Dr. Metzkes, it's all yours. You want to come up to share, or you can come up and I'll come back.
I'll give you a quick break.
Okay,
just,
good. Give me a quick break.
Yeah, and I can also take the first question if you want me.
Okay.
So one of the things that just really became clear by your questions is really how does this apply to the protocol, right? And really one of the things we've struggled quite a bit is the ESSDAI. So here's the dilemma, just to give you a little bit more background. The ESSDAI is the only disease activity score for Sjögren's that has been validated. There's nothing else. This is the only one. And it's been only validated for primary Sjögren's, really not taking into account what do you do with all these overlap patients, with these patients who have mild other autoimmune disease that are eligible for our trial. For that particular reason, and then really going forward, if you look at the clinical trials landscape right now, there's only one phase 3 trial in Sjögren's syndrome that uses the ESSDAI as a primary outcome. So for that particular reason, and Europeans feel extremely comfortable with it. That's also one of the things to say, as we as Americans haven't been using it as much, but in Europe it's been quite established and quite widely used. So for that particular reason, we really wanted to incorporate it, the ESSDAI, but we did not incorporate it as the primary endpoint for the particular reasons that there may be challenges in scoring and that it's a hard instrument to use and a hard instrument to score. So just to highlight this, so again, we do allow patients with other autoimmune diseases such as RA and SLE to enter as they're well controlled with the per the judgment of you as the investigator. And we just want to reiterate that the instructions we give for the secondary endpoint is we trust your clinical judgment here. Again, it's not the primary endpoint, it's a secondary endpoint. And we will trust your best clinical judgment here. And we also understand that, given that it hasn't been as widely used in the United States, that at one point in time we were planning to give a retraining, and we're all, Dr. Ford and me and Afsim Osafarian, we're always here to any particular question or anything going forward. So again, while this seems a little counterintuitive, we tell you you can enroll patients with other immune disease, but you shouldn't score them if you think the joints are active due to the other disease and not the Sjögren's. How would you know? Again, use your best judgment. It's a secondary endpoint, and we'll go from there. So one of the things also to highlight, which, again, just highlights the challenges of doing clinical trials in this disease is really, if you look across the ESSDAI, it has 12 domains, has above 120 points. However, really, there are in other clinical trials, or it has been shown, there are actually only 4 domains that are sensitive to change. And these are also domains which we think are more relevant for Sjögren's, and hence at screening we do randomize based on the score of the composite score of the biologic and the hematologic domain. Again, some score and for most clinical trials, the challenge is also, as Dr. Ford has highlighted, we have 120 points on the ESSDAI, but yet, if you look at the inclusion-exclusion criteria of most clinical trials, they will not allow the most severe patient to enter, right? Because if somebody has highly active renal disease, we cannot have them on placebo in this particular trial. And the same for if somebody has highly active CNS disease, are they actually able to do all the required things in this clinical trial? And would you feel comfortable with somebody having them on like 12 weeks or 24 weeks of placebo? So again, like, challenges with the ESSDAI, that it's a proof of concept study, not primary endpoint. We're asking you to do your best, give us feedback, and we will retrain as needed, we will clarify as needed, and we'll go forward. Again, like trying to find outcomes that are sensitive to change, clinically meaningful, and actually and approvable and can move things forward. So what we're really trying also to avoid as a company is follow the trap of all these lupus kind of like trials, right? Every time I look at the ESSDAI, I feel very much reminded of the SLEDAI, right? It's very similar domains, quite difficult to apply. And again, like half of the patients that could score very high on the SLEDAI are actually not really allowed to go into the trials. And and then we come back to like not every domain is actually as sensitive to change in those clinical trials. So one of the other things to highlight is for the protocol consideration is, we do assessments for CBC, CK, C3, C4 at actually every visit. And when you score the ESSDAI, the recommendation is for the grading to use the CBC associated with the visit. And if that, for whatever reason, should not be available because the blood clotted on the way to the lab or anything, just use the last available value. For the biologic domain, again, for the complement, CH3, C4, and CK, we do get, apologies, is also the muscular domain for the CK. We get those at every visit. However, the cryoglobulins, the clonal component, and the IgG, we only get at selected visits because these are really components that are not very fast to change. I mean, we can see a CBC change within a week. We can see a C3, C4 change very fastly. But a clonal component, cryoglobulin, and all of these things take a little time to change. So here we want you to use the last available value that you have from the last visit, potentially to score the domain. So again, we understand there's going to be more questions to come. We understand this is not perfect, but I think it's really a way forward and help us to identify the domains that really makes the most sense going forward. And one of the other things to highlight, one of the questions that came up, yes, while there are no specific contraindication for some of the domains, it's really in the exclusion or inclusion criteria. Like for instance, you have to have a creatinine clearance above 60. So basically, patients with renal failure are already excluded. So that takes away the high score. There are certain considerations like for discontinuation and for WBC count to be included. So that takes also away the highest score of the hematologic domain. So these are the things, obviously, they're not going to be as sensitive to change in the clinical trial settings here. And we're aware of that. Okay, any questions, concerns about the protocol? I preemptively set them all, hopefully. So, Dr. Ford, do you want to do the questions? Yeah. So now the quiz starts, and passing.
First here. Okay, good. All right.
Now,
okay.
If you came in, I should have fallen off.
No, we would want that to be with the music, to the music. All righty. Do I? Where is it? Here it is. Okay. So we're going to go to our case scenarios, and what I'll do is I'll read the question, and then we'll pose the choices, and then we'll have our music, and we ordered some special music, right?
No, we didn't.
We didn't. Oh, well, that's okay. We need some wake-up music. So this case is a 40-year-old female with a diagnosis of primary Sjogren's, and she presents at her first study visit. The diagnosis of Sjogren's syndrome was made 3 years ago. Initially, her main manifestations were rashes associated with Sjogren's syndrome, cytopenia, and renal involvement. Please choose the single best answer to score her manifestations. Oops. Are we there? Okay, I'm sorry. Her skin examination is significant for a widespread rash of raised edematous papules and target lesions that involve her legs and mucous membranes. You estimate the rash covers approximately 20% of her body. The cutaneous domain should be scored with the following activity grade. A, the rash extends to 20% of body surface area. Therefore, the cutaneous domain should be scored as highly active. The rash is consistent with erythema multiforme. Therefore, the score is independent of the distribution and should be low disease activity. A biopsy is needed to confirm the diagnosis and activity grade of this domain. And D, the rash should be scored 0 in case it has been present for 6 months or more. Okay. Let's see how we did. Okay, interesting. So, let's see, pretty good. However, let's see, any comments on this, or do you think that was straightforward? So I think everybody did pretty good. Okay, we got the E multiforme.
So I think one of the things when I initially read, when I was starting to do the trainings and I was starting to look at the outlines of the cutaneous domain, one thing that wasn't clear to me is like, is there a difference if somebody has erythema multiforme? Like, what is the distribution of? So the body surface area really applies to the cutaneous vasculitis and not to SELA or to EM. And that is very kind of like counterintuitive because it feels a little bit unlogic, but really the scoring is the vasculitis score is based on distribution and how much body surface area you cover and if you have ulcers or not. And for this particular one, while you feel like, oh my God, 20% of EM on the body surface area, this patient needs to go to the ICU, it still only gets you a score of 2, right? And one of the things also to highlight is you really nicely, like only 11% thought that a biopsy is needed. So the criteria are that if a biopsy is there and you have confirmed it's EM, you would use it for scoring. However, in cases where you do not have a skin biopsy, you would always go by the clinical picture. And in the case of EM, this would be the classic target lesions. So, so really to highlight again, this domain does not require a biopsy to be scored. But if you have a biopsy, you can use it for scoring. And that's a common theme across the ESSDAI, same for the renal domain. If you have a biopsy to score it, great, but a biopsy is not needed. The only domain where you may need a biopsy if you don't have an MRI and don't have the EMGs would be the muscular domain. There's like one confirmatory test needed. It's like kind of like an exception to the general theme.
Absolutely.
And then just again, the D was, nobody pushed D, so that's great. So the rash should be scored 0 in case it has been present for 6 months. I mean, here in the case of like, so this is just trying to highlight if something is for 12 months and you think it's due to damage, it gets a score of 0. But it's 12 months, and B, in the case of erythema multiforme, that just, that's a very hard call to call this like damage, right? Because It's raised erythematous, it looks like an active rash, right?
And as rheumatologists, I think that most of us have seen erythema multiforme, and actually, I haven't seen it in a long, long time. And so when I was reviewing these, I had to remind myself, I know what that is. So if we see it, and basically that is erythema multiforme gets that rating. And so if you see it, it's there, that's what it is.
Yeah, and the same
we
for
can feel
subcutaneous
confident.
lupus.
Right.
Subcutaneous
SCLC.
lupus, independent of distribution, is always scored with moderate disease activity,
Exactly.
right?
Exactly.
Yeah.
Okay.
Okay.
Any questions on that one? All right, next one. So now we're going to the articular domain. Is that the first that I go past? Do we start that with?
Yeah, that's the first one.
Okay, so she complains of widespread joint pain, worse in the morning, responsive to NSAIDs and corticosteroids. And on physical examination, she has 6 tender joints, including her knees, her hips, and wrists, but she has no joint swelling. She reports that both of her wrists were swollen last week, but today she's having a good day. So the articular domain should be scored with the following activity grade. A, before scoring with low disease activity, need to confirm the morning stiffness of 30 minutes duration. B, the patient's report of 2 swollen joints should be taken into account, and the domain should be scored with moderate activity. Or C, the reported symptoms are sufficient to score low disease activity, even in the absence of morning stiffness. And D, the presence of 6 tender joints on 28 joint exam is consistent with high disease activity. Music, please. Okay, let's see how we did. Okay, pretty good. 58% had before scoring. And does anyone just want to shout out why that is? What's the caveat there that puts you in that category?
She has no joint swelling.
And even more so, what's the one thing you have to have? The morning stiffness, and it has to be confirmed. They have to tell you that that there is morning stiffness there. And I think pertinent to your question, the low disease activity would be arthralgias, hands, wrists, ankles, accompanied by the morning stiffness. And moderate would be 1 to 5, and then the high would be more than 6. And so the patient's reported of 2 joints. She's telling you that you don't see them, so it's not on the exam. And the reported symptoms are sufficient to score low, even in the absence of morning stiffness. No, you have to have the morning stiffness. And the presence of 6 tender joints on 28 joint count exam is consistent, but it has to be swelling, synovitis, not just tenderness.
Yeah.
Okay?
And I think the confusing part about this one, when I first read it, was really, to me, like, because, and that's how we wrote the questions, was really, so you have somebody we really think who has inflammatory joint pain, you have the subject, responds to NSAIDs, responds to corticosteroids, her joint symptoms go away with that, and yet, unless for the purposes of the ESSDAI, unless you confirm the morning stiffness with her, for the purposes of the ESSDAI, this would not be considered inflammatory joint pain, which is, again, maybe different than your clinical practice, but this is how the disease activity score is written, and the instruction of the disease activity score are given.
Okay. So now, in addition to the joint pain, she has widespread muscular pain. She has a concomitant diagnosis of fibromyalgia. She takes gabapentin for this. And her other medications include hydroxychloroquine. She's on an ACE inhibitor and NSAIDs. Her CK is mildly elevated to 1.5 times upper limit of normal on physical exam. She does have pain with motion against resistance, but she isn't exhibiting any weakness. So, A, before scoring the ESSDAI, confirmation of myositis by either EMG, MRI, or biopsy is required, and results that are more than 6 months old cannot be accepted. B, before scoring the ESSDAI, confirmation of myositis by either EMG, MRI, or biopsy is required. results from the patient history is acceptable to use. C, the activity should be scored as low based on the elevated CK. And 4, in the absence of muscular weakness, no disease activity level should be scored independent of the CK value. Music, please. Okay, let's see how we did here. So very good. 44% had before scoring the ESSDAI. So the point here again is that you have to have documentation of the myositis by EMG, MRI, or a biopsy at some point. And if there's no weakness and the CK is less than twice normal, then it is a low score. The choice number 1 states that results that are more than 6 months can be accepted, and they just have to have that documentation, which has been done. It doesn't have to be that particular time limit. And the activity should be scored as low based on the elevated CK. It's going to be based on the presence of the myositis by the parameters measured. And in the absence of muscular weakness, no disease activity or level should be scored independent of the CK values, and that's not true either, because you can have no weakness and then have the score. I mean the proven by EMG, MRI, or biopsy.
So
Okay,
again,
did you-
the instructions are very clear. You just have to have proven biopsy at one point in time. Doesn't matter when or where. Once you have that, once you have
You don't need it again.
documented this, and then the patient would have presented the way she would have presented, then C would have been correct. So C is incorrect just because we didn't tell you. We didn't even say she didn't have it. We just didn't tell you that it was documented before. And as Dr. Ford has highlighted, again, like it seems a little counterintuitive, but the scoring of the muscular weakness is actually independent of the CK level. So somebody with proven myositis, if they have 4 out of 5 or a reduced strength, they can be scored as moderate disease activity or high disease activity. And that, again, is a very challenging thing for me as a clinician, because,
That's right.
how do you feel if the CK is normal, right?
Right. It's kind of counterintuitive to the way we evaluate, but with the disease activity, you want to start basically with the lowest, and you want to accumulate, and that's how you get up to your higher score. So her complaint is mental fog and disabling fatigue. She recently had to decrease her workload, and she can't do her job the way she used to, so functionally she's impaired. She has an extensive neurologic workup, including MRI in the past, and no specific organic reason was identified for her complaints, and they haven't changed. And on today's examination, her neurological exam was normal. So the CNS domain should be scored with the following activity grade. A, should repeat the workup. It's needed for the purposes of the ESSDAI training. B, the patient's report of disabling fatigue is sufficient to score moderate activity. C, fatigue should be scored in the constitutional domain. And D, the lack of abnormalities on MRI supports absence of active CNS involvement. Let's see how we did here.
Oh no, we're stuck.
Oops. Okay. Very good. Majority said the lack of abnormalities in MRI supports the absence. So MRI is normal, she doesn't have it. So this was kind of the opposite. We're taking away, we couldn't add anything because she didn't have anything abnormal. So you don't need a repeat workup for the purposes of ESSDAI scoring, because we've excluded her having anything because she's had an extensive workup. And on today's exam, her neuro exam is normal. The patient's report of disabling fatigue is sufficient to score? No. Because that's not part of it. And So her lack of abnormalities get her the score that we have here with the absence of any CNS involvement. Let's see, do I cover everything? Yeah. Okay, biologic domain. She has laboratories and they show that she has a low C4, lower limit of normal, below the normal limit rather of C4, but she has a normal C3 and CH50. Her IgG is slightly elevated with 16.5. There is no clonal component on immune fixation of urine and serum, and her cryoglobulins are not present. The available value at disease onset indicates presence of cryoglobulins, and SSA and SSB antibody titer is highly elevated. So the biologic domain should be scored with the following activity grade. A, the correct score is low disease activity. B, the decreased C4 in the absence of any decrease in C3 and CH50 is most likely not clinically relevant, and therefore it shouldn't be scored. The presence of an elevated IgG, highly elevated autoantibodies, and decreased C4 indicates severe biologic activity criteria, and therefore the highest activity score should be used. And the history of positive cryoglobulins should be taken into account when scoring this domain. So, music. So we're slowing down with this. That's to allow thought. How we do. Okay, so the correct score is low disease activity. You got 70%, so that's pretty good, so pretty clear there. So she has a decreased C4. It doesn't say in the absence of, it's a C4 or a decrease in any of the complement components, and it is relevant. And the presence of elevated IgG and highly elevated autoantibodies indicates severe biologic criteria, so that is not what gets our biologic domain, because it's presence of cryoglobulinemia with or hypergammaglobulinemia or high IgG levels greater than 20 and or recent onset of hypogammaglobulinemia or recent decrease of IgG levels less than 5. So the correct answer is number 1 with low disease activity. Dr. Maticus, anything to add?
No, absolutely not. And I'm actually very happy about that we get these numbers back.
That's right.
Because I thought we were going to do a little bit worse. But
So I told you we should have made them harder. See, she
Yes.
wanted to.
we should have made them harder,
made them
right?
harder.
You know, we were kind of back and forward on this. So
That's right,
I think
we
one
did.
of the things I wanted to highlight is really that, in some of the domains, and again, it becomes a little bit confusing, right? In some of the domains, we allow the history of, right? So you have the history of the skin biopsy that confirms the rash you can use. You have the history of the muscle biopsy that confirms that you had inflammatory myopathy at one point, and then going forward, you don't use a reworkup anymore. In the biologic domain, we don't allow this. So just having a history of cryos doesn't get you the points. So that is really like a biologic component, sensitive to change. And also, as you probably will give us feedback, we're hoping we got the cryoglobulins, we're hoping the testing will work out fine, but we all know cryoglobulins are sometimes hard to detect because of the multiple steps one has to take to ensure the sample is taken correctly, processed correctly, and sent correctly to the lab. So again, just highlighting one of the more challenges with the instrument, but also with the disease and the laboratory assessments.
Okay. All right, hematologic domain. Her CBC shows the following abnormal values. She has a white count that's normal, and a lymphocyte count is 545. Her hemoglobin is 9.5. So upon further questioning, she endorses complaints of heavy menses, and she's had a recent workup for anemia, and it showed low iron and low MCV. And review of her lab values reveals stable lymphopenia before the onset of anemia. So choose the right single best answer. A, the correct score is low disease activity based on the lymphopenia only. B, the correct score is moderate disease activity based on the anemia. C, the presence of lymphopenia and anemia indicates two activity criteria, and therefore moderate disease activity should be scored. And D, iron has to be supplemented before scoring the ESSDAI to see if evaluating her anemia is mixed or it has have an autoimmune component. Okay, gonna have over 70, I know. Let's see. Right there, right almost over 70, but we were right there. Okay, the correct answer is number 1. So the only criteria there is her lymphopenia. We have an excuse for her anemia. She has MNC, she has a metabolic component with the iron level, and so her correct score is low disease activity based on that white count being for, the lymphocyte count being 545, and our hemoglobin being over 80 to 9.5. So the correct score can't be based on anemia because we have a reason for that. And the presence of lymphopenia and anemia indicating two activity criteria. There isn't anything that says you have to have two criteria to make a score. And there's nothing that says that the iron has to be supplemented because you're evaluating her on the day that she comes in, and those are the scores that you obtain.
And really just highlighting again, the intent is to detect autoimmune cytopenias. Right. And while there is a slight chance that she may have a component, right now we have an alternative explanation, and the alternative explanation negates the scoring of the anemia.
Right, and we actually recently had a discussion, as a matter of fact, last week with Dr. Soror, because I was kind of leaning on, if it's inflammatory, it's inflammatory, and, why the autoimmune component, but she absolutely, that's the way she put it, has to have an autoimmune component. So even, just that if it's chronic inflammation from the inflammatory and acute activity level of her Sjogren's, that's not the anemia that she's looking at.
Yeah, again, highlighting a challenge here between your clinical gestalt, because from feedback from rheumatologists, we really hear what you see in your clinical practice most commonly is really anemia of chronic disease, and yet no point for that.
That's the autoimmune cytopenia. Okay, and we've got one more. So the renal domain, which is somewhat challenging, and line by line, I think that you will get used to all of these. I think it would be like asking all of you, okay, now of your patients, you're going to do the SLEDAI, and you're going to do one of those domains. It's difficult, and it just has to be done over and over, and our familiarity with it is what we require. So her urine analysis is significant for the following. She has no white cells in her urine. She has hematuria with red blood cells that are too numerous to count. Her proteinuria is 0.8 grams per day, and her GFR is 80 cc's per minute. On further questioning, she reports that she's had heavy menses on day of providing the urinalysis, and a repeat UA does not show any cellularity. We look at her chart, and it indicates that the proteinuria and the GFR have been stable below 1 gram a day for about 13 months, no changes. And she hasn't had a renal biopsy, so none is available. So choose the best answer. A confirmatory renal biopsy, even in the past medical history, is needed to ensure that the proteinuria is due to active renal involvement with Sjogren's. B, for the purpose of the ESSDAI scoring, the presence of red blood cells in the UA with concomitant proteinuria is always to be scored as highly active. And C, based on the proteinuria, low disease activity should be considered. And D, the presentation, is consistent with damage and should be scored as no disease activity. My last sentence there, I can't get through it. Not my 70. See what we've got. Ah, interesting. Okay, so let's go through this one. So I think everybody almost agrees that we don't have to have a confirmatory renal biopsy because if you have it, you're going to use it, and you don't have to repeat it again if you've had it. You don't continue to redo. So that's not correct. For the purpose of the ESSDAI scoring, the presence of red cells in the urine with concomitant proteinuria is always to be scored. And then she has Ramensis, so we have a reason for why she has red cells. And she reports that. She doesn't have any cellularity. So pretty confident that that's due to her cycle.
Yeah, and we also included a repeat UA that did not show
didn't
any
show
cellularity. So I think that was, it's getting a little late. So
That's right.
Really, she had the urine sample. She had her period. We've asked. She came back. It was we repeated the UA, and there was really no RBCs anymore. So again, highlighting the alternative explanation for the red blood cells, and therefore not being counted as activity score.
And so C, based on the proteinuria, low disease activity should be considered. So mild active renal involvement limited to tubular acidosis without renal failure, which she doesn't have any evidence of renal failure, and her GFR has been stable below 1 gram, so that's where it's been. And we know that for, say, 13 months, we have that there. That was somewhere else, but it's been stable, so that hasn't changed. And the proteinuria between 0.5 and 1 without hematuria, and we've repeated it, so she doesn't have that.
So I think the key is really
And
the
stable
stability of the proteinuria. So while it's a low-level proteinuria, and again, like we indicated, her proteinuria and her GFR has been stable below 1 gram per day for about 13 months. And per the definition of the ESSDAI, which is more conservative than like the lupus activity criteria, really 12 months of stability in the absence of any other activity criteria would indicate more damage. And again, I can see where people would score her with a low disease activity because you feel like, oh my God, you shouldn't have this proteinuria. But then on the other hand side, we try to present the case as if there's no other disease, like no other renal activity criteria. So that was the intent of it. So
Right. And we're trying to measure change, and that's the purpose. We're trying to measure change over time. You can't measure that if it's been 0.8 for the entire 13 months, so it's over a year.
Exactly,
So
and that's
we're not
why she
measuring
gets a zero
A
for this
zero.
one.
Right, so no
Even
disease
with a
activity.
proteinuria, even with an eGFR of 80, which is a little low
Absolutely.
for a 40-year-old lady, right? Even with that, she still gets a zero because everything is stable for 13 months, so over the 12 months period that is allowed per the ESSDAI definition. And in addition, we have no other things. Well, initially there was the hematuria, the repeat really didn't show that. So we have no other means to identify activity in this particular.
And Dr. Maxey's actually, she and I went through each of these, and we had disagreements, and I think we came down to 3 final that we had to have Professor Sarar have the final word and let us know that that's what it was. And so renal was one of them.
Yes.
And that stability, if it's less than 60 and it's stable, then it's stable. So
even
you
if you have
this.
damage, which is really counterintuitive, you can
Yeah,
be on dialysis due to your Sjogren's. If it's stable for
If it
12
hasn't
months,
changed, does
you
not
get a zero.
scored.
And again, just highlighting the same problems that we have with the SLEDAI or with the lupus disease activities. They're trying to measure change.
minimal
This is
change.
not a damage criteria.
Absolutely.
Yeah, and that was the last
So-
question. Well, thank you so much.
You all have
and
done great. Thank you for
and
your
thank you to
attention.
all.
We have some questions, yes.
Curiosity, when you said that this has been used in Europe, do you mean for studies or is it generally used in just clinics?
Well,
The ESSDAI.
It is primarily designed for the use in clinical trials, so it has been used, but the familiarity is such that it can be applied. So these are
So
available.
almost like a CDI or SDI, like we do for,
It's been
RA.
mostly for research purposes.
Okay.
So there is no like similar to the SDI and CDI that we are as rheumatologists now required once a year to document disease activity. And that particular part, it's not like used in clinical practice, but it's used for research purposes, for cohorts, and so not outside of the clinical trials.
Because now I feel better about myself.
Oh, absolutely. Well, it's similar when we look at how we score our patients in lupus trials. It just makes yourself, oh my God, this is what I should be doing to really see disease activity, not just how you're doing.
The insurance companies are insisting that they want a SDI score,
Absolutely.
right? I mean, and I'm thinking that if they're doing it in Europe, they're doing an SDI score, so that's kind of odd, right?
Yeah.
Well,
Because
again,
it's
this
a tough
is-
scoring. It's a tough metric.
It is. It
It
is very
is.
difficult.
It
And as
is.
Dr. Metz said, this is something that is all we have right now. This is our gold standard. This is being used, and I think everyone is interested in looking for additional disease activity scores that are going to correlate more with how the patient feels. Because right now we don't have a good correlation. We have our measures, but there's still problems with the consistency, what the patient feels. We may think that it's high activity. The patient says, I'm just fine. What do you mean by that? So if we're going to gear our therapy toward these numbers, we are going to have a more advanced or a continuum accumulation. I mean, even with Dr. Saror's levels, they have been evolving, and she keeps having to add and adjust and amend based on what we know, such as the skin biopsy.
Change as well. I mean, you're documenting one, and then, that does not define very much, but it's later on if that changes. It's just the delta you're looking at.
That's right.
And one of the things you're
Very
it's
right
very
on,
true.
spot on.
And one of the things to highlight, so the things that has been validated, like what's some clinically meaningful change. And again, the scale is over 120, and the minimal clinical change is free.
That's right.
So just highlighting the challenges of like having an instrument that spans the whole disease, but you're looking at the change and the domains that are changing, and they're hard to score.
That's right.
It's a work in progress.
It is.
Absolutely,
It is.
and I really much appreciate the work that Dr. Zaror and Dr. Ford have been doing, because they're both working on a
Yes.
training module, so that
Absolutely.
will also be available to.
Yes, so
through
we're
the-
working on something that's similar to the LFA online training. So we're working on clinical scenarios, and we were hoping that it would be online and available by the middle of the year, but it's already June, so I'm not sure if we're going to be able to get it
If you
done.
made the deadline.
That's right. We have to move it out, but there will be online training that will be able to be used by pharma and with site involvement and being able to do it online and getting a certificate. So to be decided by whatever company, how often, what score, how it should be repeated, et cetera. But hopefully, definitely before ACR. Hopefully, definitely. Goal.
I find it interesting articular domain, the mild and moderate assessment. For the mild, you're talking about arthralgia of hands, wrists, ankles, and feet. While the moderate, you're using the 28 joint count, which actually does not include ankles and feet, but includes the shoulders and the knees and elbows. So,
Yeah.
So-
what should we be asking the patient?
So this
about
is
their
not
pain?
the DAS 28. This is pretty much the Sjogren's 28, and that's what Dr. Saror decided to use. She's using the count of 28, but it's not to be confused with the DAS where we exclude that.
No,
Well,
but
but what I'm asking
the
is-
instructions very specifically, and there is a disconnect. I see your question is there are several disconnects in the instrument itself.
Yes.
One of them is that for the scoring of moderate and severe, you're using the joint count, which does not include the ankle and the feet. But for the scoring of the mild disease activity, you would count if somebody complains about pain in their ankles and And, and even the morning stiffness doesn't have to be in the joint where you have the pain, just the presence of morning stiffness. So these are the instructions that are specific for the
So you
SDAI.
would disregard their complaints of axial joints, like the shoulders and the hips?
Yes, these are the
So those don't
instructions.
count in a mild.
Yes, and again, it's not a perfect instrument by no means, and there are several small discrepancies like this that you highlighted, and you can find them, throughout, like, with the lymph nodes where she says, where the group says any lymph node bigger than 1 centimeter, but in the inguinal part it has to be 2 centimeters. They never say except the inguinal part. So, but there's also like a translations, certain things, right? It's a European instrument. France is so much more ahead of in clinical research regarding this, the ESSDAI as well as Sjögren's as one of the main domains. And definitely, like, some of these, sometimes I feel they're getting a little bit lost in translation.
Absolutely. And they're very proud of this ESSDAI. A lot of work went into it.
But,
There are
and
over
again,
200 sites.
you're the first and you're the
right.
only one.
That's right. So we encourage everyone to express ideas and concerns, and maybe we can go forward.
Maybe the
and help.
ACR can do one.
That's
Maybe
right.
the Sjögren's Foundation.
That's right. So listening. Absolutely. We'll be the vehicle to take it there.
Any other questions? And again, like, excellent point, Dr. Lee.
Absolutely.
Minor salivary gland biopsy, how particular do you have to be in terms of making sure everybody has one? Minor salivary gland biopsy, every patient has to have one. Interpretation of them and things like that. There were some details in the book.
So yeah,
That's
so for the definition of the for making the diagnosis, I would refer to Appendix 7, which has the AECG criteria. And for the purposes of the AECG criteria, you can actually get around without ever having you can actually be diagnosed with Sjögren's without ever having a biopsy.
Okay.
So there is a possibility, if you use that particular set of criteria, especially in secondary Sjögren's, that you are able to diagnose a patient without ever having this particular procedure done.
Okay.
And again, and Dr. Lee also earlier highlighted, even the classification criteria are quite hard, and some of them do require quite special procedures or quite special assessments. And we'll ask you to do your best to document as much as possible. But if you send your patient to a peripheral ophthalmologist, they may not be familiar with the X, Y, and Z score. And I apologize, I forget the name right now that we're using in the AECG criteria. But there's a lot of very specific requirements in there, and we're just trying the best to apply this criteria.
Okay. Thank you.
And we understand it's hard. Mm-hmm. But the ACR EULA criteria aren't that much better.
Well, thank you so much. Thank you for your attention, your presence, and I'm looking forward to our journey forward. Thank you so much.